Hi, it's Dr. E with manualtherapist.com and physioanswers.com. I had a request to show various treatments for lateral epicondylitis. So this would be assuming you've ruled out cervical spine, thoracic spine, shoulder pathologies, but in general, if it is true lateral epicondylitis and it's from an overuse, especially maybe more common like a sedentary person or a tennis player, although someone like a tennis player or golfer or rotational sport activity, I would absolutely do the SFMA and look for other restrictions. Sedentary office worker, generally you're probably going to look for shoulder issues, cervical issues, forearm and wrist issues at the most, because they're probably not doing a lot of ballistic rotational activities that may be hammering away at this mobility joint. So I'm not going to spend too much time on assessment, but typically they would have for subacute and more chronic presentations, there'd be limitation in radial nerve mobility. So we're going to start with lateral upper arm treatments. So prepping the area first with some tool-assisted or instrument-assisted soft tissue work. I'm going to use the edge and start with the sharper, smallest convexity and work along the pattern of lateral biceps and triceps and anterior deltoid. So I'd work that for about, say, 3 to 5 minutes and then recheck radial nerve mobility to see if that helped, as typically this would help improve shoulder internal rotation. She does have a little restriction here around the junctional area of the posterior deltoid and triceps, so potentially you could work on that as well. So that would be this pattern, and reassess radial nerve mobility. Now in terms of functional release, if there were areas that I couldn't strip out with IASTM, I would find a restriction with my fingertips, say right here, and I would want to bend it transversely, as that's a bit more aggressive than stripping parallel to the tissues. And just going to release this for, again, 3 to 5 minutes, or until it just improves. So again, that would probably typically improve internal rotation, just trying to separate the various muscle bellies. After that, again, recheck radial nerve mobility, or recheck some sort of concordant sign or asterisk sign. In her case, if it was grasping, or grasping with extension, or resisted extension, wrist extension. So for forearm treatments, I would progress along the neural container, the radial nerve, or that tissue pattern. And most people want to do posterior treatment, and certainly there could be some adhesions or scar tissue, adhesions more distal and scar tissue around the actual previously irritated area, so you may want to smooth that out. But I find that many people ignore the anterior portion, so you're mainly working on the bony contours or along the bony areas of the radius. Potentially, again, you could even use, if you're in the cross friction, I don't do too much, you can use the smallest convexity, but I would use the dull side, and you can cross friction. Again, I don't really find that necessary. But you don't want to forget about the anterior side. There have been a definite handful of cases that have been more help doing the anterior radial bony contours rather than the posterior. So you can start off scanning superficially with the sharp edge, and then work those areas and eventually progress depth. And she doesn't actually have very many restrictions, because she is just here to demonstrate. So again, I would work along this area all the way down, recheck radial nerve mobility. For functional release of the forearm, again, you're going to find typically more restrictions on the anterior side, most likely because those are the grasping muscles. So when I find something, I'm going to pin it, and then to perpendicularly bend it, I can do either active assistive or passive pronation. If I wanted to stretch that, I could pin, pull proximally as we do active assistive or passive wrist extension. Same thing on the other side as a progression. I can do pronation and wrist flexion and ulnar deviation. And what's that look like? It looks like a radial nerve mob. So I can progress that into a combination radial nerve mobilization and functional release. As a progression as well, after radial nerve mobilization, if they still have symptoms, but you need a little bit more of a force progression, you can grab the radial head and put it in under neural load, and then do glides to the radial head. You okay with that stretch? Also, as a progression, and again, maybe 2 to 3 weeks in, if they're still not responding or plateauing with other treatments, you can hold them in radial neural load, maybe even have them side bend their head away. Go ahead and bend away. Sorry, not turn, bend. There you go. No extra charge for that. Cavitated several times. And then you can do your tissue work along that pattern under neural load. So for manipulations, let me come around here. I learned one from Lori Hartman many years ago. This is difficult to actually get a cavitation because when it needs to be released, it will just actually cavitate, and typically there might be some kind of radial head positional fault, whether you believe in that or not. But you're going to provide a little distraction. I'm grasping the radial head with an index and thumb here. I'm going to do a little distraction, a little lateral glide. I'm going to circumduct until I feel the most amount of tension, and then the thrust is a lateral glide through the ulna to gap the humeral radial joint. So again, that doesn't typically get a cavitation unless you really need to. That's also very similar to the Mulligan lateral glide technique, and you can do it like that or you can do it like this. I typically do not use a belt. So you do a pre-test, go ahead and grasp if grasping was painful or resisted wrist extension. So go ahead and grasp and just say that hurts and relax. So if you do, it's almost like a shear where you do a medial glide here, lateral glide here, and go ahead and grasp again. And then you can play around with that if that's, say, 99, 95% pain-free. You can twist more medial here, you can twist more laterally here. You can try varying degrees of flexion or extension, more forearm pronation, supination, but always holding the lateral glide in all those varying components. You can use more force, you can use less force. But if you mess around with that for about 5 minutes or so, and you can't get it to be 100% pain-free, then you abandon the technique because Mulligan should be 100% pain-free. For home, they would typically, go ahead and film here, do that against a corner. Maybe put a towel, hold up towel here, or a pillow. So they lean into the wall. The wall is actually providing the medial glide here, and then they can do the self-lateral glide with the ulnar border, just to the olecranon. They can play around with elbow flexion, extension, supination, and pronation. Hold the lateral glide until they find it to be pain-free, and they can do grasping or wrist extension, whatever their concordant sign is. They can do that a couple sets of 10, maybe hourly, and that should be better within a couple days if they're going to respond to that particular technique. So the last techniques then are will be Mills manipulation. Go ahead and can you have a seat here on the stool. All right. So this is designed originally to actually tear any adhesions into common extensors, although most likely it's just just as much mobilizing the humeral, ulnar, humeral radial joints. You may have a lot of neurophysiologic effects with this as well. Sometimes you get a cavitation. This can be rather painful. So you can take them, put them in a radial nerve-like position. The thrust actually is through the distal posterior upper arm, but it's by side bending the trunk quickly toward the patient, which then makes them go into rapid elbow extension. You can see him actually flexing the wrist and ulnarly deviating, just similar to a radial nerve mobilization. Take a deep breath in, exhale, relax. Good. That hurt? Okay. Yeah, typically that may really bother someone, not only because I've never had anyone complain about having pain in the extensors. It usually just hurts because you're jamming the joint with typically a bony end feel into end range. And if they should have a springy end feel, more of like a capsular derangement, that is also very painful because you're smashing the two bones together and pretty much obliterating the capsular infold. Now for home program, she could go ahead and could you sit just with that arm up here? Oh, just like put the stool and scoot forward. So you want to have their forearm actually resting. And what you're going to do is you're going to use your one hand, and I know this is the opposite arm, but this is just easier the way she was sitting. You're going to lift only with this, and then you're going to give resistance with this hand as you slowly lower this wrist. So this would be eccentric loading, and I would do this and typically use the rules. Go ahead and lift up again. Lift. So only lift with the one hand, and then resist eccentrically on the way down. I think it's easier than using a weight. It should be passive on the way up, eccentric on the way down. Typically 3 or 4 sets of 10, a couple times a day, and they can eventually add more and more resistance with the other hand. So as long as they don't go above 5 out of 10 and use MDT rules in terms of increase no worse, they should again have if it is more tendon remodeling that's needed, this should help within 2 to 3 weeks, especially with rest and IASTM and radial nerve mobilizations. So they could also do a self-radial nerve mob where they're reaching out and fully internally rotating elbow extension, and they could do this to mobilize the nerve more here, to mobilize this part of the nerve. They can keep this in wrist flexion and ulnar deviation, and then just oscillate at the elbow. And they could eventually progress to side bending away in either position. And I would usually prescribe that about 30 seconds of oscillations, 2 or 3 sets several times a day. So that's how I would typically treat lateral epicondylitis or lateral epicondylalgia if it's chronic, with my eclectic approach, other than things like rest and ice and bracing.